Pertuzumab and trastuzumab, they have transformed the treatment landscape for HER2 positive breast cancer. So in all the settings, whether it is neoadjuvant setting, whether it is adjuvant setting, or in the metastatic setting, the combination has the role. So it has clearly a beneficial drug over the trastuzumab alone when we give pertuzumab plus trastuzumab combination. So in Neosphere study, we can see that there is clear advantage that patient will have plenty of PCR rates, and these PCR rates can go up to 60–70%. Similarly, in the adjuvant setting, if the patient they have been operated upon without receiving any neoadjuvant chemo plus pertuzumab plus trastuzumab, these patients have advantage if they have node positivity or a large tumor burden. Similarly, in the metastatic setting, upfront use of trastuzumab plus pertuzumab has the overall survival advantage, and you can see here that the survival advantage is to the tune of 56.5 months versus 40.8 months. So this is an approved drug combination, and this is recognized by the international guidelines, NCCN, ESMO, and all over the world. So this is a nice flowchart which explains how to treat our HER2 positive patients. If patients have less than 2 centimeters of the disease, that is clinical T1, then the option comes that these patients may just directly go to the surgery. After surgery, if you find that there is node positive disease, these patients should receive pertuzumab plus trastuzumab combination, total of 18 cycles. If there is no node positivity, paclitaxel plus trastuzumab is option for 18 cycles. Similarly, if the tumor size is more than 2 centimeters or there is node positivity, the tumor burden is high, these patients should receive at least 4 to 6 cycles of pertuzumab, trastuzumab plus chemotherapy, followed by surgery, which can result in PCR. And if there is a PCR, we should have 18. If we have PCR for this patient, these patients should receive at least 18 cycles total of pertuzumab plus trastuzumab. But if in case they have residual disease, 14 cycles of TDM1 should be given to these patients. But the IV infusion of pertuzumab and trastuzumab comes with a lot of challenges. They can have problems in the healthcare system where plenty of patients are in waiting. The long infusion times and observation times are important in the infusion when we give it at clinic or hospital. At least 30 to 60 minutes for pertuzumab is needed, followed by 30 to 60 minutes of observation. And for trastuzumab, it is 30 to 90 minutes, followed by 2 to 6 hours of observation for the maintenance and the loading doses respectively. So long infusion time and observation time is one of the challenge. Second challenge of improving resource utilization. So IV preparation takes a longer time than subcutaneous preparation, and it requires more of resources as compared to the subcutaneous preparation. Third is the thing I think is the most important thing. You need to have the placement of maintenance indwelling catheters. So many of the indwelling catheters, they can lead to infections, they can lead to thrombosis, discomfort, and a sense of fear to the patients. So this is, I think, the third one is the most important problem which we all ever face when our patients who receive prolonged number of cycles with pertuzumab and trastuzumab. Then challenge of venous access in some of our patients. Establishing IV access can be particularly problematic when patients have received plenty number of cycles of chemotherapy, having multiple venipuncture and thrombophlebitis. So Phasco is first of its type formulation, which is a single combination of pertuzumab plus trastuzumab, and this is presented in a vial for subcutaneous injection. It contains same antibodies as approved for IV preparation of pertuzumab and trastuzumab, but has different route of administration. The novel combination here is recombinant human hyaluronidase. So this is the recombinant hyaluronidase because of which we are able to inject our patients 15 ml of the total dose or 10 ml of the maintenance dose for our patients. So giving a 1 ml or 2 ml injection in a subcutaneous manner is a problematic thing. But with the advent of this RHUPH20, this is not a problem anymore. So it is ready to use fixed dose formulation administered by subcutaneous route in the thigh, and it approximately takes 5 to 8 minutes. So what is the mechanism of action? These are the two basic antibodies which we have pertuzumab and trastuzumab. They are fixed dose combination, which is administered subcutaneously, and primarily it is combined with the recombinant human hyaluronidase. So how does this work? So hyaluronidase is an endoglycosidase which is used to increase the dispersion and absorption of the co-administered drug when it is administered subcutaneously. So this is the layer of the skin. The subcutaneous layer contains the matrix of the hyaluron fibers and the collagen tissue, which limits the subcutaneous administration to the volume of less than 1 ml. So you cannot administer 1 to 2 ml of the drug in the subcutaneous space because of the presence of these fibers, collagen fibers and hyaluron fibers. But the addition of this recombinant human hyaluronidase to the FASGO, it temporarily and locally degrades this layer. And when you degrade this layer, there is no change in the structure providing the macromolecule. The degradation of the hyaluron is resulting in the temporary increase in the local subcutaneous dispersion area, and it enables the large volume of the fluid to be administered. And the beauty of these things is that this architecture can be reformed within 1 to 2 days due to the rapid clearance of this drug and the fast hyaluron turnover. The formulation with this drug allows for the subcutaneous administration in the large volume, that is 10 to 15 ml of the drug we can easily administer with the combination. So this is how it works. So you can see here that this is the bolus injection which has been given without RHU-pH 20, and you can see that a bump has arisen here. But this is immediately post transfusion of the 10 ml of IgG solution, which is containing RHU-pH 20. So you don't find any bump here when you administer such a large amount of drug in the subcutaneous space. So then the important question comes to our mind whether it has the same pharmacokinetics and efficacy as that of IV preparation of pertuzumab and trastuzumab. So the Roche has this FASCO clinical development program, and the finding and the confirmatory dose for pertuzumab within FASCO was done in phase 1B trial, and this was BO 30185 clinical trial. It was completed in May 2018, and the recommended doses for loading are 1200 milligram of pertuzumab and 600 milligram of trastuzumab, and this should be followed by maintenance dose of 600 milligram pertuzumab and 600 milligram of trastuzumab, which is a fixed dose combination. So the pharmacokinetics, efficacy, safety, and preference, they were tested in SABCS 2019, and another clinical trial, FASCA. This is phase 2 trial in early breast cancer. This is ongoing and presented at ASCO 2020. So this is first phase B dose finding study for pertuzumab, and this was BO 30185. Once the dose of pertuzumab was found out, the patients, they were divided into 3 cohorts. One cohort received the pertuzumab separately and trastuzumab separately, the subcutaneous preparation. Another cohort received pertuzumab and Herceptin mixture that was given to the another cohort of 20 patients. And the third cohort, that is cohort C, received the fixed drug combination FASCO, that is trastuzumab and pertuzumab with a fixed dose combination. So the summary of this clinical trial was that the loading dose came out to be around 1200 milligram pertuzumab subcutaneous, and the maintenance dose came out to be 600 milligram pertuzumab subcutaneous to be used in this fixed dose combination FASCO. The PK study in the healthy male volunteer in the patient with early breast cancer predicted these doses will be resulting in the equivalent of the pertuzumab when they are given in the IV preparation, that is 840 milligram of pertuzumab in the loading preparation and 420 in the maintenance setting. The dose finding processes used to find the subcutaneous dose of pertuzumab, they were similar to those that were found earlier for the subcutaneous that is rituximab and subcutaneous Herceptin, that is trastuzumab by Roche. The safety signal, so the study did not find any new safety signal for pertuzumab subcutaneous alone or when it was co-mixed with the pertuzumab or with the fixed drug combination, that is FASCO. This is another study, Frederica study. This is phase 3 non-inferiority study for assessing pharmacokinetics, efficacy, safety of this combination. So you can see here that the patient, they were confirmed to have locally advanced inflammatory breast cancer, who had more than 2 centimeters of the disease or node positive disease, that is stage 2 or stage 3 disease. These patients, sorry, they, in the arm A and arm B, both of these patients received dose dense AC combination 2 weekly or 3 weekly, and in the second part of the trial, they received paclitaxel or docetaxel. Either IV pertuzumab plus trastuzumab was given to one arm, or the first drug combination, fixed dose combination, Phasgo was administered, whether along with the paclitaxel or whether along with the docetaxel. So the investigator tried to find out the PK and safety study in combination both with paclitaxel and docetaxel. The primary endpoint was non-inferiority of of the serum concentration, and the key secondary endpoint were the serum concentration, tumor PCR, and disease-free survival (EFS) and overall survival. So these are the pharmacokinetic parameters for this clinical trial. If you see here, the lower limit of 90% of confidence interval for plasma serum concentration, PROF and GMR of the pertuzumab and trastuzumab, they were similar in the patients who had IV preparation or who had subcutaneous preparation. If you see this tumor PCR rates in the intent to treat population or as per body mass index, the tumor PCR rates were around 59.7% in the FASCO group as compared to 59.5% in the IV group. So the tumor PCR rates were also in line with the IV preparation. So intent to treat population, they were all same, although few number were the less in the obese patients or the underweight patients, but in overweight patients or the normal patients, the tumor PCR rates were even more as compared to the IV population. So tumor PCR rates were close by in both the subgroup, intent to treat population. If you see the safety profile of this fixed dose combination, it was almost similar. You can see any event was 99% here and it was 100% here. 52.8%, 48.8% for grade 3 adverse event. Deaths same, and discontinued due to any kind of adverse event. In the IV preparation, they discontinued as compared to the fixed dose combination. So rate of the treatment discontinuation, they were similar in both the arms. You can see here that the alopecia, nausea, diarrhea, anemia, they were almost similar. So none of the side effects, they were more in the fixed dose combination as compared to the IV combination. And similarly, here are the rates for the cardiac dysfunction and neutropenia, febrile neutropenia, anaphylaxis, severe mucositis. You can clearly see here that almost all of them, they were similar. The interest were for those patients who had cardiac event. So you can see here that the p-value for the cardiac events was not significant, and there was no meaningful difference in the cardiac safety between the treatment arm. So this fixed dose combination subcutaneous showed non-inferiority of pharmacokinetics versus IV with comparable efficacy and safety. Tumor PCR rates were similar. Safety profile was similar. No new safety signal they were found. Diarrhea, febrile neutropenia, cardiac safety, hypersensitivity, mucositis, they were almost similar in both the arms. So another question, whether patient prefer to have fixed drug combination or IV combination. So this was the Franska trial, and basic question here was whether the patient would prefer having IV combination or whether the patient will have preference of subcutaneous combination. So these were the patients. They received pertuzumab plus trastuzumab IV 3 cycle, and then in the crossover period, the patient received 3 cycles in the subcutaneous formulation. Similarly here, initially these patients received subcutaneous formulation, and then these patients received 3 cycles IV. So this was 1:1 randomization. These were those patients who had completed their neoadjuvant treatment, surgery, and now they are on the maintenance treatment. So half of the population received IV first, followed by subcutaneous, and half of the population received subcutaneous followed by IV. And these are the important things which came out of it. So if you see, the preference for subcutaneous formulation is clearly more, even with the patient. So preference for the fixed drug combination FASCO was for very strongly and very fairly among the majority of the patients. So 93% patients preferred having this drug subcutaneously, and main reason for subcutaneous preference was less time in clinic. 42% patients said that, and 26% patients said that they were more comfortable with the subcutaneous administration. 87% patients chose FASCO to continue over IV treatment in this clinical trial. So the patients, they were either satisfied or very satisfied with the combination. 85% patients, they were very satisfied. So majority of the healthcare practitioner also felt that switching from IV to subcutaneous formulation would save time and resources. 88% of the practitioner thought that it was the quickest form. The preparation time was very short for these this subcutaneous formulation, and 87% of the HCPs felt that the subcutaneous formulation had less number of resource uses for preparation and administration. 77% of the HCPs agreed or strongly agreed that ready-to-use FASCO combination resulted in the less drug waste. Administered, it is the 300 minutes which are needed, but for the subcutaneous preparation, it is 33 to 50 minutes, including the observation period. So the main reasons, patient satisfaction, yes. HCP's perception on the time and resources, yes. And the safety profile similar for both of them. The patients and the HCPs, they were very satisfied or satisfied with the drug combination, less time in clinic and more comfortable administration. So what are the practical considerations for using fixed dose FASCO combination subcutaneous in the real world practice? So this is the tip to ensure that the comfortable drug delivery is to be done. Ask the patient to sit back in the reclining chair or bed to make thigh area accessible. Be sure to arrange that the chair is right at the level of the patient, and your feet, they're not twisting or bending, and the feet, they're really flat on the floor, that so that the administration is really easy. Ensure that your hands are in good position and in resting condition. This will reduce any unnecessary movement during injection that might cause discomfort for the patient. The injection site should be alternated between left and right thigh, and once you have used injection site, the next site should be on the left leg or the right leg in the next injection. And in the next to next injection, at least there should be more than 1 inch gap when you are using the previous limb for the treatment. And you have to choose the area of the skin that is not red, that is not bruised or tattooed or tender to touch, and record the use site for the patient's note. To administer the injection, pinch the skin of the thigh in the one hand to create a fold, and this makes it easier to get injection into the subcutaneous space. And do not put the injection into the muscle. That muscle can be damaged. Inject and maintain the needle at the angle of 30 degrees. If there is a point during the injection that patient feels pain or discomfort, ease of the injection before continuing. Keep the needle in place and check to make sure that injection is right at the 30 degree. Injection should be slowed or paused if patient finds that there is significant injection related reaction. The injection should be discontinued immediately if there is a chance or experience of hypersensitivity. Make sure that the injection to treat reaction in the emergency equipment is available if you are using Fasgo in subcutaneous formulation. The patient, they should be observed at least for minimum of 30 minutes for the sign of hypersensitivity symptoms or the administration related reaction if patient they are being administered. After the maintenance dose, the patient should be observed minimum of 15 minutes. So these are quick tips to administer this drug safely. If the drug is administered in the chemotherapy daycare unit, the curtain or shade should be used so that patient should be at privacy. A blanket on the top of the lower abdomen and the pelvis can be used so that the patients feel more safe and secure. So we usually follow these procedures when we do Fasgo for our patients. So this is the overall summary. Fasgo is the first formulation in the oncology to combine two monoclonal antibodies, that is pertuzumab and trastuzumab, in single vial, and it offered faster and less invasive method for the administration as compared to the IV treatment. The PK safety and safety analysis PK and the outcome, they are almost similar. Tumor PCR rates, they were almost identical in the intent to treat population, and it were not impacted by the body mass index. Majority of the patients feel that this is a good combination. Majority of the HCP also feel that this is a good combination, and most of the HCPs are now switching from IV infusion to the subcutaneous injection to save the time and resource. This drug is now FDA and EMA approved for the same indication as a type of IV preparation of pertuzumab and trastuzumab. Thank you so much for your patient listening.